Another one thing which possibly is missing in your list is chronic liver disease. I think here again, possibly your choice will be apixaban.
Yes, sir.
In pulmonary thromboembolism, what is the drug of choice?
No, that's what I said. DVT is taken as along with pulmonary thromboembolism. So we can start NOAC straight away unless patient is having an active cancer, not extremes of body weight or serum creatinine on the low or higher side. Rivaroxaban or apixaban can be started straight away. It is recommended that they are better than vitamin K antagonists nowadays in DVT as well as pulmonary embolism. But the guidelines have not incorporated that. They are saying that if it's active cancer, parenteral anticoagulation followed by VK.
To Dr. Krishnakumar, what is the now obstructive sleep apnea is a cause for the resistant hypertension. What is the incidence and what about the treatment in case of obstructive sleep apnea as a secondary cause of hypertension?
Sir, in fact, OSA is one of the common cause of secondary hypertension. And in the clinical examination and the history is very much important. You have to ask for snoring, because might be the partner might be knowing that the patient is having active snoring. And if the patient is obese, one thing is if the patient is obese and having a short neck, it is said that if the neck circumference, if the male it is more than 40 and female more than 36 is a evidence of OSA, and you should do a sleep study to confirm that it is OSA. And once you confirm it is OSA, you can give other measures like CPAP and such things.
Can you
A
use
lot of correlation between OSA and hyperaldosteronism. Now, the people have been found that these are the subsets of people who benefit from aldosterone inhibitors. Even without hypertension, people are trying MRAs in just OSA alone. So, a lot of excitement is happening in the MRA and
GLP-1 agonist in the treatment of obstructive sleep apnea.
Actually, GLP-1 semaglutide is one drug which is being approved for obesity treatment, and I think obesity is closely associated with OSA. So, for management of obesity, definitely there is a role for GLP-1 agonist.
Topic is open for discussion. Any questions from the audience?
Excellent coverage of all the things. But one aspect is when we are giving NOAC, the antiplatelet which we combine with NOAC is clopidogrel. The only exception is probably for coronary artery disease, a dual pathway inhibition. In a patient with high risk of atherosclerotic events, we can do a dual pathway inhibition by inhibiting the coagulation pathway as well as antiplatelet, where rivaroxaban is recommended as a 2.5 milligram BD dose along with aspirin. Here, it is the aspirin is the drug of choice, not clopidogrel. PVD as well as in a patient with atherosclerotic disease. When a patient with atherosclerotic disease with multiple events, diabetes, chronic kidney disease, or even multiple stents, these are the persons where probably more antithrombotic therapy is indicated. Antithrombotic therapy can be dual antiplatelets prolonged or can be dual pathway inhibition. Dual pathway inhibition by giving by trials like COMPASS trial and VOYAGE trial, where the peripheral vascular disease.
But these are instances where there is no atrial fibrillation. He was mainly talking about
the thing is, we should clearly differentiate between stroke prevention in atrial fibrillation as well as what Sibu is saying.
The topic was not in atrial fibrillation.
No, how to choose NOACs. That was the topic.
That was the only topic. It was not atrial fibrillation.
No, it was not atrial fibrillation. What Sibu said is absolutely right. In peripheral vascular disease as well as in high risk coronary artery syndrome, there are studies using 2.5 milligram of rivaroxaban twice daily along with aspirin. What I was saying was a patient with ACS undergoing stenting, we put them on aspirin, clopidogrel or ticagrelol plus NOAC. In that case, aspirin is taken off early at 1 week.
Just added this point.
Yeah, that's right. That's a very well taken point.
Sibu, we should also realize that gradually aspirin is fading away. People have found out that in chronic primary and secondary prevention, clopidogrel score over aspirin, even though the guidelines are not yet shown that.
Probably this is because there is no trial, because only the trial was with rivaroxaban, aspirin which has shown benefit. And apixaban actually did not show benefit, increased bleeding in such situation. So
Yeah,
in
we
a
have
dual
factor-
pathway inhibition, that scenario alone, aspirin and rivaroxaban is the drug approved so far.
And we have, possibly we will see factor 11 inhibitors soon in atrial fibrillation too. Thank you very much, both the speakers and the chair.